You know, it's pretty wild to think that about 1 in every 125 baby boys is born with some kind of structural genitourinary disorder. And as a future pediatric nurse, guess what? You're going to be right there on the front lines, caring for these little ones and their families. Now, these conditions can feel super complex, but your sharp eye and quick action can literally change a patient's entire life. So let's treat this as your personal study guide, a deep dive to help you master these concepts for the real world and, of course, for your exam.
So here's our game plan. First, we'll tackle the critical why behind the timing of surgery. Then we'll walk through the big categories of defects, from simple blockages to true gotta act now emergencies. After that, we're going to build a nursing care framework you can use for almost any of these kids. And we'll finish up strong with some killer NCLEX memory tricks and a final challenge to really test your clinical judgment. Sound good? Let's do it.
All right, let's jump right into our first section. Why does timing matter so much? And I'll tell you, it's about way more than just a successful physical repair. This actually gets to the very heart of a child's psychological development.
So what's the big deal with this specific 6 to 12-month window? Well, here's the really fascinating part. The source material points out that between ages 3 and 6, kids become super aware of their bodies. They start noticing differences. So by getting these repairs done way before that stage, we're not just fixing a physical thing. We're doing proactive psychological care. We're actually protecting that child's future self-esteem. It's pretty profound when you think about it that way.
Okay, now that we get the importance of timing, let's get into our first major group of disorders. I want you to think of these as issues with the body's plumbing. Either something's causing a blockage or the pipes themselves just aren't formed correctly.
So, the big umbrella term you'll hear is obstructive uropathy. It's a fancy way of saying there's a clog, a kink, or a narrowing somewhere in the urinary tract. This causes urine to back up, which, as you can imagine, puts a ton of pressure on the kidneys and can cause some serious damage. So our goal is really simple. Find a way to reroute the flow around that clog, and that usually means surgery. Picture this. You're a nurse, and you're reviewing a newborn's chart. Mom had oligohydramnios, which is low amniotic fluid during her pregnancy. Ding, ding, ding. That's your first clue, because fetal urine actually makes up a lot of that fluid. Then you see a prenatal ultrasound showed hydronephrosis, which is swelling in the kidneys. That's clue number 2. After the baby's born, they keep getting UTIs. You see? By putting these clues together, you become a detective, helping to catch this early and prevent long-term kidney damage.
Next up is Corti. This is a pretty straightforward one. You'll see a visible, downward curve of the penis, and it's caused by this tight little band of tissue. The fix is a surgical release of that band, and it's really important because if you leave it, Corti can cause all sorts of functional problems later in life. So getting it corrected is a huge deal for that person's long-term quality of life.
All right, everybody lean in because this slide is classic NCLEX material. You have got to know the difference between hypospadias and epispadias. It is all about where that urethral opening is. So for hypospadias, think hypo, like low. The opening is on the ventral, or the bottom side. For epispadias, think epi, like upon. So the opening is on the dorsal, or the top side. And check out their associations too. Hypospadias often hangs out with Corti. So if you're assessing a newborn and you see that opening on the top, what are you thinking? That's right, Epispadias. Lock it in.
Okay, now let's see how that last point builds right into our next section. We're talking about conditions where structures that are supposed to be internal are actually visible on the outside at birth.
And this brings us to bladder exstrophy. This is a really severe defect where the bladder is basically turned inside out and it's sticking out through the abdominal wall. You can imagine for parents, this is an incredibly shocking and scary diagnosis to receive. So as the nurse, our job is twofold. Not only do we have to provide immediate, top-notch clinical care, but we also have to be that rock for the family, supporting them through a super difficult time.
Right. So when you see bladder exstrophy, it's almost never just one isolated problem. You have to look for a whole bunch of other findings. Think of it as a complex midline defect. You'll often see a widened pubic bone, an inguinal hernia, and remember how we just talked about Epispadias? It's often associated with this too. It's a whole constellation of issues you need to be aware of.
So what is the absolute most critical point here? This is not a wait and see kind of thing. The second you identify an exposed bladder, you have to act fast. Your number one absolute first priority is to protect that organ. You immediately cover it with a sterile, plastic, transparent dressing. Why? To keep that delicate tissue moist and to prevent infection. Every single second counts when you're getting this newborn stable for surgery.
Now, let's switch gears to a much more common condition, phimosis. This is just a tight foreskin that can't be pulled back. And the key takeaway for you as the nurse is that this is usually totally normal in infants, and it fixes itself over time. Your #1 job here is parent education. You teach them routine cleaning, and you stress, with big capital letters, to never, ever forcibly retract the foreskin. Got it? Good.
Oh man, I will never forget my first clinical rotation and the absolute anxiety I felt assessing a newborn for the first time. This next section is so important because your hands-on assessment skills are what will help you tell the difference between a common no big deal issue and a true surgical emergency.
Cryptorchidism. It's a fancy word, right? All it means is an undescended testicle. So during your assessment, you go to palpate and you can't find one or both testes in the scrotum. The so what here is huge. If you leave this untreated, it can lead to infertility and a much higher risk of testicular cancer down the road. That's why the surgery to fix it, called an orchiopexy, is so critical and why it's timed for that 6 to 24-month window. Okay, so you find some scrotal swelling during your assessment. You're usually dealing with one of these two bad boys. A hydrocele is a collection of fluid. Just think hydro, like water. It's totally painless, and as you can see, it usually just goes away on its own. A varicocele, on the other hand, is all about dilated veins. The classic description is that it feels like a bag of worms. This one can be uncomfortable and it needs surgery. So one is fluid that goes away, the other is veins that need a fix. Easy enough, right? Okay, I need everyone to stop for a second and just burn this slide into your memory. When we talk about testicular torsion, there is absolutely no room for hesitation. The source material is this direct for a reason. This is a true emergency. Every single minute you wait increases the risk of losing that testicle. So if you ever suspect testicular torsion, you escalate immediately. You could literally be saving that patient's future. So what are the red flags? What are the dead giveaways? It's sudden, severe pain, often with nausea and vomiting. The scrotum will be warm, swollen, but the classic textbook finding is an absent cremasteric reflex. That's the reflex where the testicle should pull up when you stroke the inner thigh. In torsion, the spermatic cord is twisted, cutting off blood flow and nerve function, so that reflex is just gone. It's a massive All right, let's put you in the driver's seat. Imagine you're a new nurse on a peds surgical unit. You get an assignment for a 9-month-old who just had surgery for an undescended testicle. What do? Well, this next section gives you that universal framework, that mental checklist you need for pretty much any of these kids before and after surgery.
Before surgery, a huge part of our job is really focused on the family. Yeah, of course, we educate them on the procedure and NPO status, that's a given. But just as important is providing real emotional support. And that's not just some fluffy concept. It means actually sitting with the parents, listening to their fears without judging, answering their questions honestly. It's all about building that trust. It's key.
Then, after surgery, our focus gets super sharp, super clinical. Pain management is priority #1, always. And for some of these procedures, like a hypospadias repair, the kid might get these really painful bladder spasms. So you might see orders for anticholinergic meds like oxybutynin to help relax that bladder muscle. Beyond that, we are meticulously watching their I's and O's, taking care of the wound, looking for any sign of infection, and teaching the family all about activity restrictions. I totally get it. Studying for nursing exams, especially the NCLEX, can feel like you're trying to drink water from a fire hose. There is just so much information. That's why I created this final section, to help you boil all of this down into powerful, memorable chunks that you'll need to feel confident, and more importantly, to practice safely. Let's make these stick. Ready? Hypo is low, epi's up high. For bladder exstrophy, exposed, don't be shy, cover it now and prep for surgery. For testicular torsion, a twist is a timeout, a true emergency. And for hydrocele, just fluid-filled, it'll be fine. Use these little mental shortcuts. They really help when you're under pressure during an exam. And that brings us to our final challenge, where it all comes together. You walk into the room, you see this 10-hour-old infant. You see that exposed red bladder. So, what is your single most important priority nursing action? And even more importantly, why? What catastrophic thing are you trying to prevent by doing that one action first? I'll leave you with that to think about. You got this.